Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, the Société Francophone de Nephrologie, Dialyse et Transplantation, and the Junge Deutsche Gesellschaft für Nephrologie, Marcus at Home welcomes Dr. Anne-Laure Faucon and Dr. Marie Evans in Stockholm, Sweden, with whom we would like to discuss trends in major cardiovascular events and bleeding among patients with advanced chronic kidney disease, CKD, based upon their data from the nationwide Swedish Renal Registry, which have been published a few weeks ago in the American Journal of Kidney Disease. Dear Anne-Laure, dear Marie, thanks so much for being with us tonight. We really appreciate the opportunity to discuss good nephrological news with you at the end of this year as a kind of academic Christmas present. Happy to have you tonight. Dr. Evans is research team leader and principal investigator at Karolinska Institutet in Stockholm, Sweden, chair of the Swedish Nephrology Research Network and principal investigator of the Swedish Renal Registry, which is a national registry of nephrology-referred patients, and she is PI of the SAC study, which we plan to discuss at Marcus at Home in the not-too-far future. Dr. Faucon is senior nephrologist and epidemiologist, again at Karolinska Institutet in Stockholm. Her main research focuses are risk factors and biomarkers of CKD progression and of CKD-related diseases. Before she came to Sweden, she had been postdoc researcher at the Department of Clinical Epidemiology of the Institut National de la Santé et de la Recherche Médicale at the Université Paris-Saclay in Paris, France. So thanks again for being with us. And now, without further ado, let's hear your pre-Christmas good tidings.
Thank you very much. Good evening, everyone. Thank you very much for this very nice introduction and for inviting us to present our work on trends in cardiovascular events and bleeding in patients with advanced CKD. So as we all know, patients with CKD are at very high risk of cardiovascular disease, and cardiovascular disease is the leading cause of death in patients with CKD, with a high risk of both arterial events and venous events, but mainly arterial events. And on the other hand, patients with CKD are at high risk of bleeding and thromboembolic events, both because of CKD itself, but also because of its etiology. And on the other hand, the treatment we are giving to patients, antithrombotic therapies, induce also a risk of bleeding. So the treatment for cardiovascular disease and thromboembolic events in our patients with CKD can be particularly complex and challenging, especially in patients with advanced CKD. So data on temporal trends are important, first of all, to assess changes in clinical practices, especially in the area of new cardioprotective and nephroprotective medications, dialysis treatments, but also a wider use of DOACs. And they are also important to inform public health policies, to guide the design of future clinical trials, but also to support allocation of healthcare resources. But the studies we have published in the literature so far are quite old, and they often lack of granularity in the type of cardiovascular disease, which because they mainly evaluate cardiovascular mortality, but not specific causes of cardiovascular disease. And we don't have any data on patients not yet on dialysis. So the most recent study published so far is a study from the Scottish Renal Registry. This is a very nice study where the authors have shown that over the period 1996-2016, we observe a decrease in the rates of myocardial infarction and stroke, both in men and women, by 50%. But we don't have any data on patients not on dialysis, because this study population were only restricted to patients with kidney replacement therapy. So the aim of our study was to describe rates and to quantify temporal trends of arterial and venous thromboembolic events, but also clinically relevant bleedings in patients with advanced CKD. So for this study, we included patients from the Swedish Renal Registry. So the Swedish Renal Registry includes patients referred to nephrologist care. So mainly patients with advanced CKD, not yet on dialysis or on dialysis. And the Swedish Renal Registry is linked to other national registries to obtain the complete information regarding comorbidities, medications, outcomes, and death. So for this study, we included a patient with CKD stage 4, CKD stage 5 not on dialysis, and patient on hemodialysis and peritoneal dialysis over the period 2011 to 2021. And our 4 cohorts were matched on a control population based on age and sex from the general population. We were interested in different cardiovascular events and bleeding, such as MACE, which is a composite outcome of cardiovascular death, hospitalization for myocardial infarction, or hospitalization for stroke. We analyzed separately arterial events and venous events, and also we analyzed major bleeding and clinically relevant non-major bleeding, which is bleeding-related hospitalization that did not involve a critical site. So here is our study population. So we identify 20,591 patients with CKD stage 4, 13,968 patients with CKD stage 5 not on dialysis, 10,635 patients on hemodialysis, and 4,511 patients on peritoneal dialysis. So here are the baseline characteristics of our study populations. So as you can see on this table, it's typically patients that we used to see every day at the clinic with a median age between 75 and 74 year old, a majority of men, a substantial high prevalence of cardiovascular disease. And when it comes to medication, a substantial high percentage of patients on antithrombotic therapy. So in this study, we analyzed, first of all, incidence rates of cardiovascular and bleeding events. And after that, we analyzed temporal trends in the rates of cardiovascular and bleeding events compared to the general population. So when we look at the rates of cardiovascular and bleeding events, we can observe, as expected, that the rates increase across the CKD cohort, with rates higher in patients on dialysis than in patients not yet on dialysis, with arterial events more frequent than venous events, and also rates higher in men than in women. After standardization, we can observe that patients with CKD have higher rates of all study outcomes than the general population, as expected, with rates ranking from 1.5-fold to almost 25 times higher than in a general population. When we look now at the temporal trends, we can observe that over the period 2011 to 2021, there is a decrease in trends, decrease in the rates of cardiovascular events. For instance, for MACE, we have up to 39% decrease, for arterial event up to 28% of decrease, and for a venous event up to 57% decrease. When it comes to major bleeding and non-major bleeding, it's not very obvious on this graph because of the y-axis, but there is a trend to a decrease of major bleeding, but instead non-major bleeding tend to increase by 42% in CKD stage 4 and 69% in CKD stage 5. After standardization, we can observe that the change are slightly faster in patients with CKD than in a general population, even if the rates remain several times higher than in the general population. So to conclude, what we observed in this study, we observed encouraging reductions in the rates of cardiovascular events in patients with advanced CKD, despite the fact that our patients are sicker and sicker, with an increased prevalence of comorbidities. But in the other hand, for major bleeding, we observe a slightly decrease, but non-major bleeding instead increase. So this encouraging reduction in the rates of cardiovascular events are very encouraging, but rates remain several times higher than in the general population. So there are still challenges and still a room for improvement to improve the clinical management of our patients. So if we look at the data across the different countries, here are the US data, where the authors analyzed 1.9 million death certificates, where CKD or end-stage kidney disease was a contributing cause of death. And what we observe during the period 1999 to 2020, despite an increase in cardiovascular deaths by 20.5%, the age-adjusted cardiovascular mortality rate decreased by 7.1%, while the age-adjusted all-cause mortality rates increased by 50%. So we already spoke about the Scottish data, where in patients with kidney replacement therapy, we observe as well a decrease in the rates of myocardial infarction and stroke over time, both in men and women, by 50%. When we look at the data from Austria and New Zealand, over the period 1992-2005, we observed that in patients on dialysis, there is a decrease in cardiovascular mortality rates in patients older than 55-year-old, although the excess risk compared to the general population tended to increase at this period of time. So what we observe is, that we are doing better, and we can ask ourselves the question, but why we are doing better? Well, I don't have the response from the data we have, but we can hypothesize that we are doing better in terms of clinical practice and new medications. Here is a study from the Swedish Renal Registry, where 6,612 patients starting dialysis were analyzed. And when we look at trends in clinical practices and medication, it seems that we are doing better in terms of dialysis treatments, in terms of cardiovascular medications, but also in terms of treating anemia, CKD, MBD, and so on. And this translates into a decrease in 2-year all-cause mortality and two-year risk of MACE. Here is another study from the Swedish data, where the authors analyzed the clinical management of patients after an acute myocardial infarction, with a stratification on dialysis or not dialysis patients. And we can observe here that on this figure, even if patients on dialysis are less likely to have a cardiovascular procedure, there is still an improvement over the time. In this same study, the authors also analyzed cardiovascular medications, and we see exactly the same trends, that patients on dialysis are a bit behind patients not yet on dialysis, but there is still a tendency to an improvement in treatment after acute myocardial infarction. So we are doing better in terms of treatments for arterial events. And we also observed in our study that there is a trend in decrease in bleedings, and maybe this will be explained by the fact that we use more and more DOACs in our patients. So to conclude, there are encouraging reductions in the rates of cardiovascular events and major bleedings in patients with advanced CKD, although those rates remain several times higher in patients with CKD than in the general population, meaning that there is still a room for improvement to improve delivery of optimal care in our patients with very, very high risk of cardiovascular disease. Thank you very much for your attention, and we are happy to take your questions.
Well, thank you very much. That was fantastic. If I may start, I was really intrigued, by your finding that it seems that people undergoing PD have a higher risk than patients requiring or receiving hemodialysis. You would expect a different trend. Do you have any explanations for that?
Yeah, that's a very good question. I was also a bit surprised while looking at the results. I don't have a really good explanation for that. Maybe, Mary, you want to?
Yeah, I mean, I'm thinking that in Sweden we have quite high transplantation rates. And the majority of the patients who gets transplanted, they have PD before they get transplanted. Mm-hmm. So we would have sort of a tendency to get rid of the healthiest people in the PD group. So those who are still remain in PD treatment, those will likely be the sicker patients. So that could be one explanation.
Yeah, that makes sense. And also, I mean, it's really intriguing to see, also the trends that the risk reduction in MACE, arterial events, and so on goes down over time. Although, all the interventions we are using have largely failed if we just focused on dialysis population. Also, the Scottish registry with the minus 50% reduction in men and women is really striking. So what is the explanation for that? Because I would not guess that we are doing so much different than 10 years ago.
Yeah, that's a good question. I'm wondering in the Scottish Renal Registry, what is the part of patient transplanted versus patient on dialysis? Because maybe the huge effect that we are seeing in those results are maybe driven by patient on kidney transplantation, but otherwise, yeah, in terms of clinical management, we are doing better. But I do agree that there is a kind of, I mean, we did not expect that improvement. I mean, I don't know what do you think about it, Mary, but.
I think it's, I mean, it's in a way, it's surprising that it's actually that we do better than the general population, but maybe we are sort of catching up. Yeah. Because the general population, we know that there was recently a study in Sweden saying that in general, people survive much longer after a myocardial infarction, and there's been like substantial improvement in the rates of cardiovascular death in the general Swedish population. And maybe this is finally, the cardiologists are finally treating also our patients more aggressively, and we are doing that as well. And also all the other cardiovascular prevention that we are doing, like the total sum of it adds up to a better, like a decrease in cardiovascular event rates, like better blood pressure management, better statin treatments, etc., before they even reach dialysis. And that maybe that is what we are seeing the effect of.
And also rates in CKD patients are so high that like a small improvement can have a very strong effect. And we are starting from so high rates that as compared to the general population, that maybe even a minor improvement can have like I mean kind of strong effect in terms of reduction and so on.
And the idea that the benefit comes from before people go to dialysis is also, I guess, mirrored by the failure of so many clinical trials in dialysis patients. Whatever we did so far actually did not really have any benefit to our patients, whether we gave statins, whether we implanted ICDs, whether we went for spironolactone, tinacalcet. All these trials actually have been negative once people were on dialysis. We now just saw at the ASN this fish oil study, Pisces, which we still, I guess, have to digest and to understand better. But for all the other trials that have been done, they have been virtually negative. So might really be the better care before people go to dialysis. If I may just go back to PD versus HD. So how many people in Sweden are on peritoneal dialysis compared to people on hemodialysis? And second question, as I'm aware that you definitely have more people on PD than we have in Germany, and I guess also in Austria, is there a difference between, say, Stockholm, Malmö, and the regions far more in the northern parts of Sweden, like Norrland, I guess, where really the way to the next town with a dialysis facility is much longer?
Yeah. Yes, I can answer that. It's about 30 to 35% of the incident patients start on PD, but the prevalent number of patients is around 20% now in Sweden. So we have a high proportion of patients on PD, amongst the highest proportion in Europe. But regarding the second question, I think it is not always so easy, because some of it depends so much on the engagement and the sort of the knowledge of the doctors and nurses working at the clinic. So even though there are units which would, in my opinion, probably benefit from having a high proportion of PD because of long distances, they don't have it because they might lack the sort of the number of patients to be sufficiently have the sufficient knowledge to do treatment. And there is actually now a big initiative in Sweden trying to highlight trying to make home therapies increase all over Sweden, because we see these differences across Sweden in the uptake of home therapies.
Do you happen to know, so like in Stockholm area, are you also above, say, 20% of people on PD?
Yeah, we have a very high proportion of PD patients actually in Stockholm, because we have a strong history of the clinic. It's with a big engagement in PD.
That's very interesting for us in Germany, because we always say, well, it's much closer here to the next dialysis center than in northern Sweden. But if you say Stockholm would be the same, then actually there's no good excuse for us. I guess, Andreas, Austria is also below 10% with regard to peritoneal dialysis.
Roughly 10%, yeah.
Okay, so we are well below 10%.
Yeah, and I think that the best region in Sweden is one of the northern districts in Östersund, because they have really promoted PD and they have great long distances. So I think they have more than half of their patients on PD, actually. But there are also other regions with a much smaller uptake.
With regard to your study itself, I have two more questions to the design of the paper. So if a patient went from CKD stage 4 to 5 non-dialysis and then to 5 dialysis, is he or she included 3 times in this analysis? So starting when switching the stage and then ending the follow-up when switching to the next stage?
Yes. What we have done is we included all the eGFR measurement or dialysis status, and we constructed the cohort like this. A patient translated from stage 4, progressing from stage 4 to stage 5 or to stage 5 on dialysis could be included several times, but at a different index date, so that there is no overlap between the different periods. So patients were censored at the time when they moved to the next stage. And the start of the follow-up for the next stage started at this new index date.
And when they received the transplant, then they were censored from the dialysis cohort. And this explains the rather short follow-up, because each patient is a limited time period in the respective stage and then switch to the next stage. Okay, I got it.
Exactly, yeah.
One more question, when looking back to your earlier data from 2013 or so, even then, the difference in outcome between patients with advanced CKD and the general population is not so much increased as in elder paper analysis by Alan Go in the New England back in, I guess, 25 or something, and Dr. Jager and Jammer in 2009. And they, at that time, found actually an increase in cardiovascular morbidity and mortality by an order of magnitude or even more. So even 10 years ago, this was actually no more the case, at least in Sweden, was it?
I don't know now. Now maybe I'm now out in like fishing in another water, but you know, this GO study, I think that they used like an age standardization to 50 years.
Okay.
And in this cohort, the age standardization was according to it was age standardized to the study population, and as you saw, it was around 75 years. So it might that might give some difference, I think.
And I'm also wondering whether their CKD patients were not from the general population and not patient referred to nephrologist care, because we know that patients from the general population with CKD, for same level of CKD, basically, they are kind of different. They are not those that we used to see at the clinic, isn't it?
Okay, got it. And one more question. Now that the outcome of at least your patients in Sweden has been really improving in the last years, should we still consider people with advanced CKD like stage G4 as very high risk patients? So the European Society of Cardiology lists them among their highest risk patients, recommending an LDL cholesterol well below 55. Would you still see these people in that category, or might we even be more enthusiastic and say, well, they are at risk, but not at really this high stages?
Yeah, very good question, but I'm not sure we could say that. I think how patients are very sick, and even if we see improvement in rates of cardiovascular events, we cannot say that they are not that much sick. I mean, they are very sick, and we have to consider them at very, very high risk.
That makes it easier for us, so we do not have to change our strategies, because up to now I always recommend them, well, please go for a statin and bring it down as low as possible. And so we will continue to do so. So looking to the future, will you continue your analysis? So is this registry ongoing?
Yes, the registry, and actually, I'm not the chair of the Swedish Renal Registry, only for the CKD part of the registry. I should point that out. So the registry is still ongoing. It's we collect data which is continuously updated by all our users across the country. So we have 68 dialysis units approximately, and about 45 to 50 non-dialysis clinics which participate in the registry, and that covers about 98% of the nephrology-referred population. So we constantly try to increase our sort of the validity of the registry and the accurateness, and I think that we have a large coverage now of all nephrology care.
Yeah, it's really incredible, you know, how you put everything together, and I got to know it a bit closer when I visited Anne-Laure and Juan Jesus recently. So it's really good, and we are very curious to see what else is coming out of the registry. I think we can all learn a lot for our practice. Well, that was exciting, and we would like to thank you very much, and there will be discussion of the SAC study soon, and we hope to have you back at the channel when you present the next exciting study. Have a very nice Christmas, and I hope that I can see you in person on Monday, actually, in Stockholm. See you soon. Bye-bye.
You are so welcome.
Thank you very much.
Bye.